Welcome to Deuk Spine Institute. I'm Dr. Deuk Majin. You're watching live spine surgery. It is May 23rd, 2024. And our patient has back pain. She is from Florida, I heard. And I'm going to tell you something because you all need to know this. Back pain has many causes. Potential causes, I should say. Luis, I see.
I can get to you.
It's okay. I didn't blame you, did I? I'll take the blame myself. One of those causes of back pain is when your surgeon uses you as a pincushion. But chronic back pain lasting more than, well, there's different. What do you consider chronic?
I'd say greater than 6 months. That's what
Oh, God, no. Chronic is not greater than 6 months.
greater than 90 days?
Unfortunately, chronic is 6 weeks. Some people say it's 4 weeks, but most say 6. Acute is, a couple of days. Subacute is a few days to a few weeks. Chronic is really, honestly, more than a few weeks. But, all right. Chronic back pain has many causes, potential causes, and the most common is a painful disc. How do discs become painful? We're going to show you in a moment. It has to do with inflammation. And what causes inflammation? Injury. What causes injury? Trauma. So, we're going to see in a moment how painful discs can actually be. In her case, she has 2 discs that are extremely painful, L4-5 and L5-S1. Shot. We're going to get into the L5-S1 first and fix it. Shot. Now, before I leave the x-ray machine, we're going to get into the L4-5 as well. Let's get an AP view. You're doing great. Our patient is asleep. All right, perfect. Lateral. You can see there's a little scoliosis on the AP x-ray, right? You saw that, Henry?
So sorry about that. I was having a mini conversation with Sam. Can you repeat that one more time?
Oh, you can see the scoliosis
Yes.
on the AP.
Yes, we can. Yes.
Excellent. All right, Sean. So I'm getting into the L5-S1 disc right now, Sean. I want to stay low in the foramen, Sean. Then we're going to do L4-5. The entire surgery is done through a 7mm incision. I've already made that incision, shot. Now I need to get into the L4-5 disc. Shot. As I was saying earlier, there are causes to back pain, the disc being the most common. The second most common cause of chronic back pain is the facet joint, which, Jordan, show us the facet joint. Shot. Can you guys see the arrow? That is the joint.
Yes, we can.
Show us the facets. Facets are 2 bones located in the back of the spine that touch each other or kiss each other. They actually hold your spine from sliding forward. Those facets are the second most common cause of back pain. We need her awake. The most common cause of back pain is the disc. The disc causes back pain in 86% of patients. The facet causes back pain in 9%. You're doing great. Then the SI joint causes back pain in 2%. And the piriformis muscle basically 2%. Everything else, that's, if you add it up, that's 100%, right? Well, it's 99%. Less than 1% is fractures, tumors, infections, coccydynia, other things. So 99% of back pain, totally fixable here at Deuk Spine. Today, we're going to be fixing disc, SI joint, and piriformis. She has all of those causes. She awake?
How you doing? Okay.
Now, the piriformis muscle is a muscle that attaches to the tailbone and runs over here and attaches then to the hip.
Hey, Sam? Yes. Can you come here, please?
Piriformis. She has piriformis pain because she's torn her muscle.
Can you open your eyes for me? We're going to ask you a few questions, all right?
She's torn that muscle on both sides. We're going to release it. Now the tear happens usually around the middle.
Okay.
So people have horrible tenderness right in their buttock, right there where the tear is. She's got that. She also has pain in her SI joint right here. This is the SI joint. So we examined her and found horrible pain in the SI joint, pain in both piriformises, and pain coming from her two discs. And we're going to fix all of those today. So she has 1, 2, 3, 4, 5 causes. 5 causes of back pain. And the problem is most surgeons, they can't figure out where pain comes from. Nobody knows. At Deuk Spine, we do. We use our Deuk Spine pain map. All right, are we ready?
Yeah.
So this is how much blood we'll lose the whole surgery. It's about 10 drops of blood. And we only lost that because she's on some type of a blood thinner. We don't know what it is. Could be Red Bull. Could be ginkgo biloba, fish oil, turmeric. There's lots of herbals that make your blood thin. Are you in pain?
How are you doing? No pain.
All right. We're going to get you back fixed. Dr. Deuk here. I just need your help for a moment. All right. How bad is that on a scale of 1 to 10?
Give us a number.
What's the highest it went? What's 10? Is that where you get back pain? 10 over 10 concordant, L4-5. You guys see the tear? Show us the tear. Is that better now? All right, good. Sorry about that. Jordan, circle the tear. Circle it. Yep, that's it right there. That's the tear. It's about 2.5, 3 centimeters long, and it's about 9 millimeters tall. You okay? All right. How bad is that on a scale of 1 to 10?
Give us a number. Don't move your hand.
What's the highest it goes? 10. Is that where you get pain? You get to go to sleep. When you wake up, that pain will be gone for the rest of your life. We found your pain. All right. So this lady is special. She's from Florida, and I did a telemed with her, MRI review. At the time, she was still walking, but in the last 2 weeks, she's lost the ability to walk. She's now in a wheelchair, can't get out. She's in so much pain. I hate seeing that, and it's all because of this pain that she has from her discs, piriformis, and SI joint. And we're going to fix that today. Now, you see the facet joints?
Yes, we do.
Okay. Look at 4-5, Jordan. Show us 4-5. Look how wide that joint is. Jordan's touching the space between the bones. That is wide. The reason it's wide is inflammation. Now, I didn't find facet pain on her, I don't think, but she's got inflammation in her facet joints, and hopefully she doesn't have any pain there ever, but she may have pain there in the future, so we'll have to fix that as well. But it's definitely a widened facet joint due to inflammation and swelling inside the joint. It's a fusion. You ready? All right, here we go. We're going to get started. I guess you want to start with 5-1, right, Luis? Yeah, here we go. Needle comes out, guide wire stays in. We're going to put this dilator down. It's going to spread the tissues because all of our tissues are fibrous. Fibrous. Okay, think about and for the vegetarians out there, don't hate me. Think about a piece of beef jerky. I was eating some last night. I'm not a vegetarian. Think about those pieces of meat, right? They're in fibers. If you rip a piece of beef jerky, it just kind of shreds into pieces, right? Those are muscle fibers. And inside your body, you have all this fibrous tissue that has fibers. So we're going between those fibers. We're not actually tearing them, we're going between them. And we're spreading them apart, we're separating them. Kind of like if you take a safety pin and put it through your shirt, okay, or your jacket, it spreads the fibers apart. Hold on, shot. It's looking good. Let's take it out. Shot. Alrighty. We are in L4-S1. And we're going to do our first disc repair. If you have questions, feel free to ask them. Henry, why don't you show the audience how is it that a disc herniation can be so painful? Okay, welcome back, and now you can see why we're operating on the disc. The disc is the source of back pain. It's not the whole disc that hurts, it's just in the back. And that's a fact that we discovered here at Deuk Spine Institute. I discovered it with my son, Arias, doing research. Turned out that there's a tear in the back of people's discs with back pain from the disc, and that tear gets some of the nuclear material stuck in it, and it creates inflammation. And when you get all that inflammation going, well, that causes pain. So the fix is simple. You go in, find the tear, use a laser to clean it out. Now to do this surgery, you obviously have to have a surgical skill. You have to be trained endoscopically, you have to be trained to use the laser. And I went through all that training and have been performing this surgery for 18 years. So we have treated over 2,000 patients now. Our numbers are going up every year. We're getting more and more awareness of the community and public about that back pain can be diagnosed and cured at Deuk Spine. We're the first in the world to do it. We're the first in the world to offer a guarantee. We don't guarantee all of our surgeries, but we guarantee certain ones. And if a patient, for example, has pain after the surgery and they have a guarantee in place, then we continue to treat all the sources of pain until it's gone. It's very common. About 20% of our patients will come here with multiple pain sources. We'll fix them, and lo and behold, they have another one that wasn't diagnosed because they didn't have pain there before surgery. So for us to fix their pain, we got to know where it comes from, because our treatments are targeted. These are what are called targeted treatments, meaning that we're treating a specific structure, not the whole back. We're treating the source of pain, which happens to be, in this case, the tear. Now remember, I told you a few minutes ago the tear is about 3 centimeters long and 8 millimeters wide. Let's round up to a centimeter, tall and wide. So you're talking about a volume that is 30 millimeters by 10 by 10, right? A tube, a cylinder, 30 by 10 by 10. That's a very small volume. But it's a strategic volume. It's literally in exactly the wrong place that causes all this pain. And if you take all the back pain sufferers around the world, 100 million people, 200 million people, however many it is, 180 million out of 200 million have this exact cause that we've discovered at Deuk Spine. And the problem is, it's just doctors aren't paying attention. We're telling them. They don't want to hear it. So you got to ask yourself, why are these doctors that treat back pain, why do they not want to know the truth? Why do they not want to know what causes back pain so they can fix it? And the answer is they don't want to fix it, obviously, right? If you tell somebody that their house is on fire and they don't do anything, they just stand there and let it burn, as long as they're sane, then you have to accept the fact that if they're not going to do anything to stop their house from burning, they want it to burn. I mean, there's lots of things you can do. You can call the fire department, right? You can call for people, your neighbors, to come help you try to put it out. There's a lot you can do, but the one thing you don't want to do is you don't want to do nothing. And these doctors that treat back pain that don't want to treat the source, they just want to treat the symptoms. They're never going to cure the back pain for the patient. They're only going to treat the symptoms. And the patient's going to have to keep going back for treatment. Well, if you as a patient have to keep going back for treatment for your back pain, is that good or bad? So if you have an option of getting a cure or going back and getting treatment that never cures it and only makes it a little bit better, which would you choose? Now, I could be wrong about this, but I think most people would choose to cure. I would. Okay? So why don't other surgeons cure back pain? Yeah, I think it's a good idea. It's awfully cloudy. All right, so the answer is, I think they don't want to cure it. Now, you could argue some of them don't know how, and that's why we have to get the word out about what we're doing, so they can learn how. Yeah, we got an irrigation.
Let's see it now. Better now? All right, thank you, thank you.
Yeah, what was the problem, guys?
Oh, what's here?
Yeah. Thanks. All right, let's take some questions.
This first question coming from We the Captain Now on YouTube.
Oh, nice. We the Captain Now. Welcome to our live stream. Thanks for asking questions.
Asking, hello, is the laser disc repair for this patient similar to a microdiscectomy at both levels?
No. No, microdiscectomy is a procedure that's old and it doesn't work well. And more importantly, it's only for treating leg symptoms, not back pain. This patient has back pain. And most patients have back pain. So microdiscectomy is not a treatment for back pain. Microdiscectomy is an old-fashioned treatment where, can you hold this down?
Yes, sir.
Where basically the surgeon goes in and removes your muscle. Literally takes the muscle you have on your spine and takes it off. We don't do that. We don't damage the muscle at all. Then the surgeon cuts a hole in your spine called a laminotomy so they can get down to the disc to do the discectomy part of their surgery. You need that bone, by the way, but they take it out anyway. Taking it out makes your spine weaker, more susceptible to re-injury. Then they take out part of your facet joint as part of the microdiscectomy. It's called a partial facetectomy. Well, you need your facet joint too, my friend. Imagine taking off half your knee. How do you think you feel afterwards? Not good. The knee won't work normal. Neither does your facet joint work normal. That's part of the treatment. It's part of the microdiscectomy. Then, as though taking your lamina off and your facet off wasn't enough, now they're going to take the ligaments that hold your spine together out. They take out the ligamentum flavum. So, they've taken your muscle out that holds your spine together. They've taken your facet joint half out. They've taken your lamina out. They've taken your ligament out. And this surgery doesn't do any of those things. We don't take any of those things out. Zero, zippo, nada, none. Hold it. Basically, microdiscectomy starts out by destroying your spine. But that's okay, because you can't see it. You don't know about it. They won't tell you about it. But if you read about it, that's what they do. Okay? I used to do it. That was what I was taught to do. But it's a horrible procedure. Then, after your spine is destroyed by the surgeon during the surgery, then we get to the discectomy part. Now, to take the disc out from a microdiscectomy, you have to take the nerve root. You got to grab it and you got to pull it off to the side. I mean, you really york on it hard. So hard that a lot of patients end up with spinal fluid leaks after those procedures. We don't have spinal fluid leaks after this procedures because we're not yorking, retracting, and damaging the nerve. Okay? The nerve is naturally above where we operate. We don't have to pull it away. Then the surgeon has to cut a hole in your ligament. Your posterior longitudinal ligament, that is. So this is the next ligament they destroy to do a microdiscectomy. Yet they still haven't taken your herniation out, have they? No. Haven't even gotten to the part that actually helps you. So they've removed your ligamentum flavum, they removed your posterior longitudinal ligament, and they also took out your interspinous ligament, supraspinous ligament a lot of times, all destroyed during the surgery. And yet they still haven't done what they need to do. Finally, they get the nerve root moved over, and there's the herniation. Now, the problem is they can only take the herniation out that's located in the center of your spine, central or paracentral, but not the foraminal herniation and not the lateral recess herniation. With this surgery, we don't damage the muscle, we don't damage the ligaments, we don't remove any bone, we remove nothing. We actually spread things apart because it's such a small tube, and we use a laser to just remove the herniation and clean the tear. That's all. So this is a much safer and better surgery. Plus, with this surgery, you can get a paracentral, central, lateral recess, and foraminal herniation, which you can't get with a microdiscectomy. And then at the end of the microdiscectomy, you have all the scar tissue and bleeding and pain. So you have to take narcotic painkillers. With this surgery, we don't have any bleeding. We don't have any scar tissue. And patients don't really have any pain. They just have a little bit of pain and they take Tylenol. Then with a microdiscectomy, you're out of work for a long time. With this surgery, you can go back to work right away. Okay? So, a lot of differences. Good differences, but important differences. This is a much better surgery. Microdiscectomy is old technique, very dangerous, very damaging, doesn't fix back pain. All right, great question. Next.
Next question coming from Holly on YouTube,
Hi, Holly.
asking, can traumatic injury be from a single event or just over time, and what is the most likely in this case?
Traumatic injury can be single or over time. I can't really tell you what happened in this case, but look at this stuff here. This is old, old, old. This is like 20-year-old injury, at least. When I say 20 years, I mean at least 20 years. The amount of scar tissue right here is massive. This is extremely dense. This is like on a scale of 1 to 10, this is an 8. I've had 10s. This is an 8. So this scar tissue here is like at least 20 years old. So this person's injury is at least 20 years old. Okay? And I think she said her pain got worse recently. I believe it. Probably did. Probably had another herniation recently. See the blue thing? That's a herniation, by the way. I'm going to take it out. All right. I feel pretty good about that. By the way, we never get all the herniation. We only get 50, 60, 70, 80% maximum. No doctor can get 100% of a herniation out. It's not possible anatomically. It would be like you looking around the entire world by just standing and staring outside. Your eye can't bend around the earth. So when it comes to the spine, there are things that block our ability to get the whole disc out, like the pedicle, the facet, the nerve root, fecal sac, things that the vertebral body, things we can't remove during the surgery. So, great questions.
This next one is coming from Rita on YouTube. This is a comment and or seeking advice. They said, I'm chronic. I think I'm from 2008 pain. Sorry, missed the beginning. Trying to catch up. Took methotrexate, making me sick today. Doctor calling, but I'm trying to build my case for Canada to send me to you since they don't have your surgery. Someone said if they don't have procedures needed here in Canada, is a chance they'll pay, but not for flight or stay. But maybe most of the surgery. Please pray for me to win. I'm a bleeder. I love watching you tell about the scams. Thank you. You're brave and honest to tell the truth when you know surgeons don't like it, and actually my knee pain so bad would like it out for a breather, but I know what you mean.
Yeah, thank you so much, and we appreciate your words of encouragement for us and kindness, and I hope and pray that you get the help that you need, whether it's here or somewhere in Canada. All right, next comment.
Next question coming from Tony on YouTube, asking what replaces the tissue that is taken out?
What replaces the tissue that's taken out? So Tony, what we're taking out is not normal tissue. It's the herniation. It shouldn't be there in the first place. So what's going to replace that in that gap right there is actually the patient's annulus will heal. I just think Jordan's off a little bit. He's got the double shadow on the pedicle. We're off on WAG. I'd like to see a better picture. In other words, we're not taking any normal tissue out. We're taking the herniation out. The herniation is out of place. It shouldn't be there. Okay, go ahead. Shot? Shot? Yeah, her herniations are really hard, scarred up. So what's going to seal off that hole at the end when we're done is her body will actually seal that up. We're pretty much in. Yeah. Her body will seal that hole. What will take its place is collagen. Collagen. Your body makes collagen to heal injuries. Collagen and elastin. That's what's going to go there. Good news is that that's... What is this I'm hitting? Is this an arm board or something? Yeah. It shouldn't be there. Okay? I got to stand here. That can't be there. I'm okay with it right now, but in the future, Grabber, we got to not have the arm board so prominent. I'm not sure what's going on. All right. So we're inside the herniation right now. I've literally pushed it back into her disc. See the blue stuff? That should be white, not blue. So the fact that it's blue means the dye is binding to a degenerated nucleus. That is supposed to be white. Normal nucleus pulposus is white. The fact that it's blue means it's damaged and the body's inflammatory system has been attacking it. So it's a sign that it's totally abnormal herniation. When you look in the scope, even after we inject blue, there should all be white. Nothing should stain blue. In a normal disc, nothing would stain blue. Okay? The only reason why this disc has blue stuff is because what's staining blue is the nucleus pulposus, the jelly from the center. And it only stains blue because it's acidophilic, meaning acidic. Acidophilic, it likes acid. So it binds the dye, which is meant to bind degenerated nucleus that's acidophilic. Basically, it's a way of tagging the bad stuff that I have to remove. Apologize for the poor visibility. All right, any questions?
Yes, this next question coming from Tina on YouTube,
All right, Tina.
asking what will be her recovery time?
Tina, believe it or not, her disc recovery is going to be overnight. The surgery will be overnight. And 90% of our patients, 90, the next day have no pain. 90. 10% have pain for a few more weeks after they leave, but it goes away. So I would say her recovery is going to be less than 2 weeks. She's going to leave here in an hour after her surgery. That recovery is that fast. There's no hospitalization for the surgery. This is outpatient. She's going to be up walking around tonight. She's going to go to dinner with her husband. Well, I'll say for her she's in a wheelchair, so maybe she won't be walking around. But normally patients would be up walking around tonight. Will she be walking around? That would be maybe too much to ask for because she's been in a wheelchair for a few weeks. So let's talk about that. That's important. You know, when people come here and I get rid of their disc pain, their back pain, one thing I can't fix is their muscles. Muscles, when they're deconditioned and really in bad shape, they're skinny and shriveled up and they don't work well. Well, those muscles take years to rebuild. Years. Okay? There's the tear, by the way. And I can't rebuild muscles for people. We don't do that. It's not possible today. Maybe in the future it will be. They can leave here with all new muscles. Right? Wouldn't that be nice, guys? We do surgery, and while we're doing surgery, we grow muscles for them in a petri dish and stick them in. I just think we're far away from that. That said, why do people's muscles shrivel up? Well, they're having pain. They can't walk. They can't, run. They can't jog. They can't exercise. They can't do the things you and I maybe take for granted. And because of that, they do a lot of sitting around. And where everybody else is walking around at Disney, they are sitting in a wheelchair. And guess what sitting in a wheelchair does? It makes it so their back doesn't hurt as much, but they lose their muscle mass, you know? And it happens quick. I was told by a very good physiatrist, that a patient laying in bed for one day, it takes 7 days of therapy to get that muscle back, that muscle condition back. So imagine these people, for years they put off surgery, and their muscles are deteriorating for years. It's going to take a long time to get that strength back, that endurance back. So one thing I can't do is I cannot rebuild muscles overnight. It just doesn't happen. Nobody can. Second thing I can't do is I can't make nerves that we've unpinched, I can't make them heal faster. I can just unpinch them, and they're going to heal at whatever rate they heal. Some people they're better overnight. Some people they take a few weeks. Some people they take longer. So I just tell everybody, give your nerves 6 months to a year to get, go back to normal. Because that way, if it happens sooner, they're happy. If it takes 6 months to a year, well then, that was the long pathway, and they ended up in it, All right, we'll take questions.
Next one coming from Rita, once more on Facebook, YouTube.
Yes, Rita, we're going to be done soon, in about 5 minutes or less. Say 5 minutes. And when we're done, Henry's going to end this broadcast, and we're going to resume with a sacroiliac joint Deuk plasma rhizotomy. Because this patient not only has disc pain, she has SI joint pain on the right, and she has piriformis pain in both butt cheeks. She has bilateral piriformis muscle tear. So I'm going to have to treat all of that in just a few minutes, but we're going to break it up into separate live streams. That way, on the YouTube channel, we can catalog it better, so it's not confusing to people. Otherwise, it'll be really confusing. Somebody watching a Deuk laser disc repair and seeing me cutting a muscle in the butt, that wouldn't be very good. They're going to wonder what the heck I'm doing. Wow, look at this. Herniation just goes on and on and on. This is the what, 4-5? Yeah, this is the newer herniation. But you guys can see the tear, the white thing that's torn. That's the annulus fibrosis. And it's got a lot of scar tissue. I will say this disc at 4-5 is a younger tear and herniation, more recent. The one at L4-S1 is older because of the amount of scar tissue and the amount of degeneration, the amount of calcification. All right, take the question.
This next question from Rita, once more on YouTube, asking, is the laser in place of stitching tears when you repair? My neurologist said I'm only his only Takayasu patient, but you said you have had Takayasu patients. Can I ask how many you had?
Yes, I've had at least 5 Takayasu patients in the past. Remember, I've been doing the surgeries for almost 28 years. And Takayasu arteritis I've known about for, well, at least 32 years. But I personally operated on, in my practice here and that I've been in for 20 years, at least 5, maybe 6 or 7 to be exact. And then before I came here to practice medicine, I was taking care of Takayasu patients in neurosurgery at Shands Hospital in Gainesville, and we had probably about 5 there as well. So you can say at least 10 patients with Takayasu's. You had some at UCLA. Dr. Berndes has taken care of Takayasu patients. So we're not too concerned, right? I mean, from a surgery standpoint, I'm not worried. Are you worried from an anesthesia standpoint?
Not at all. The only thing would be
Not at all.
if they're on any type of biologic therapy for for the healing afterwards, but they don't make a
Yeah.
large incision, so
Yeah.
okay.
The thing about our surgeries, we're not making a big incision.
A
So,
lot of them are on biologics.
and if you're on a biologic, you'll have to talk to your doctor and
Rheumatologist.
make sure you notify them you're considering to have spine surgery so they can adjust your medication regimen appropriately. All right, Henry, who's next?
Next question from Lee, the captain now, once more on YouTube.
Sure.
Saying, thank you for your expertise. If a patient has a history of herniated disc, lower back pain with increasingly worse leg pain, does that imply the disc herniation has become worse?
Yes, that does imply the herniation has become worse. You may not see that worsening on the MRI, but the only way to get more symptoms is through more inflammation. The way you get more inflammation is when you get more herniation. Yep. All right, any more questions?
Yes. This next question coming from Tony. Coming from Tony, once more on YouTube. Asking, do most of your patients require only one of your surgeries?
Do most of my patients require only one surgery? Yes. 90% of our patients need one surgery. The other 10%, they come for something else. So if we fix their discs, then maybe they come back and they have facet pain or sacroiliac pain or piriformis pain, and we have to do another surgery. But it's never on the same thing that we already fixed, unless they re-herniate, which happens 1%. We've had 20 patients re-herniate in 20 years. It's about one a year. And we've done 2,000 of these surgeries, so think about it, it's 1% of our patients will re-herniate. And we have to operate on the same disc. So to answer your question, 10% of my patients come back and have another surgery, but it's always something else I'm operating on besides what I did the first time. So they have other causes of back pain or neck pain. And then 1% of the patients re-herniate, and I have to operate on the same disc again. Hopefully that clears it up. Yeah, our re-herniation rate with this surgery is 1%. The re-herniation rate with a microdiscectomy is about 90%. Just about done. This is a really scarred up part right here. You guys see all that scar tissue right there I'm working on?
Yes, we do.
This is because of the herniations created all the scar tissue. Her body has been attacking this thing. This is why she's been in so much pain. If her body was not attacking the herniation, she wouldn't have any pain. She wouldn't have any pain at all. She would have a painless herniation. All right, you can see we're pretty much done here. I'm gonna hit it one more time with a laser, and that's it right there. Luis, you got the tube?
Yep.
30 seconds. Guys, we're gonna end the stream. We're gonna come back in a minute. We're gonna have you watch our sacroiliac joint Deuk plasma rhizotomy. All right, Henry.